Hi guys, so today we're going to be talking about how to approach pediatric emergencies. We're going to identify children that require immediate intervention, recognize and differentiate respiratory distress from failure, and know what the early interventions are for the respiratory conditions of distress and failure. So, do you know how to identify a sick child? These four pictures are some of the classic examples of children who are quite unwell. On the first picture, you can see mottling. The second picture, you can see a child who has a kind of neck swelling. He's leaning forwards in the tripod position. His mouth is open. The third child is having bruising or petechia. And the fourth child is also having a diffuse rash and looking quite tired and lethargic. So, how do we decide whether a child is well or not? The answer lies in the PALS or the Pediatric Advanced Life Support algorithm. There are a total of 4 steps which we need to follow, and we're going to discuss each of them individually. So, we start off with the initial impression. Next, you will evaluate. Thirdly, you will identify or come up with a conclusion of what the child has. And fourthly, you will intervene. Now, as we go through it, you will find that these steps are linked in a cycle. You start with evaluation, move towards identify, and intervene, but you will be intervening whenever you find a problem. So, at any point in the evaluation that you find an issue which can be rectified or intervened, for example, low oxygen, you'll attach the oxygen and continue with your evaluation and assessment of the child. We'll be discussing it in more details in the coming slides, but the point is to remember that they're all interconnected and should be happening simultaneously together. Starting off with initial impression. So, just as it sounds, it's the first quick observation when you step into the child's room. What is going on? Is the child fine or is he not fine? What is the tool you're going to be using? It's called the Pediatric Assessment Triangle with 3 components: appearance, breathing, and color. Now, what are the components you're looking for in appearance? Because you need to have a degree of objectivity when you're describing a child's condition from one observer to another. So you'll be using the Tickles mnemonic. What is the child's tone, interactiveness, consolability, the look, gaze or stare, and the speech or cry of the child? Is he looking lethargic, floppy, sleepy, or is he crying inconsolably? Uh, is the child, interactive, not interactive? It's a good indicator of how his overall condition is. Coming to B for breathing, you're going to be looking at the position of the child, the work of breathing, and the breathing sounds, not necessarily by auscultation, but just by getting the sounds which are clearly audible in the room, like wheezing, stridor, grunting, gurgling sounds. You can see in the picture this child is in a tripod or a sniffing kind of position. And color. What is the color of the child? This is a very good indicator of the circulatory status if you want to get a quick snapshot just from the first look of the child. You can see a lot of things like we saw previously: mottling, rashes. You can see in this child how she's having flushing of the cheeks, swelling of the lips, most probably having an allergic reaction. You look at the skin and also at the mucous membranes. So you have done the initial impression in which you looked at the appearance, breathing, and the color. Now you're going to move towards the evaluation step. So using the initial impression tool, you're able to identify whether this child is in need of any urgent intervention or not. If you look at the algorithm on the right side of the screen, you will see that after initial impression, the first question that comes up is the child unresponsive or in need of immediate intervention? If the child is not well, you will shout for help and you will activate the emergency response system, which means that you're going to assemble a team and you're going to put the child under the radar and start your assessment in details. So we're going to move towards evaluate. Within the evaluation, you have two stages, or you say 2 degrees of assessment, primary and secondary. The primary assessment is basically the head to toe screening of the child. So how is it different from initial impression? Initial impression, we said we're just looking at the appearance, breathing and color on an overall basis. The primary assessment is in more details, and you're going to follow the mnemonic of A, B, C, D, E. A for airway. So is the airway clear or not clear? That means, are there any secretions, any blood, any foreign objects? Is it, is the child breathing comfortably, or are they getting some kind of obstruction? As an example, let's say you have a child coming in with an active seizure. They may be drooling, they may be having gurgling sounds coming from the mouth. So if you have from the get-go identified that the airway is not clear, you're not going to continue with the rest of the assessment just yet. You're going to suction the secretions, re-evaluate. Once the airway is clear, then you will continue on. So this is the point I was trying to mention earlier, that all things should be happening in a loop, or somewhat, simultaneously or side by side. Is the airway maintainable or not? Maintainable airway means that the child is awake and alert, able to, maintain the correct posture required for the airway to be open. If it's non-maintainable, for example, the child is, drowsy, he has taken some medication overdose, or he's post-ictal, so he is not fully alert. This means that you need to manage the airway with possibly intubation, or you need to, evaluate for that. B for breathing, you'll be looking at the rate, the effort, the air movement, the lung sounds, and the oxygen saturation. And again, let's say you have found that the child is having low oxygen saturation, you'll attach them to the oxygen supply and then continue with the rest of your assessment. If you found that the child is wheezing, you will give them a bronchodilator and then continue on. Circulation, you'll be looking at the heart rate, blood pressure, the capillary refill, and the skin temperature. Here again, let's say commonly child is hypotensive, tachycardic, you'll give them a fluid bolus and re-evaluate. D for disability. Here we have 2 tools to assess for the child's neurological status. AVPU is a quicker and easier way to assess the neurological status, or if you have more time, you can do the GCS, pupils, and the blood glucose test. E for exposure, here you'll be checking for fever or hypothermia in the temperature, signs of trauma, skin rash, or extremities, for fracture, for any rash, any injuries. So after you've finished the primary assessment, you'll move to the secondary assessment. Here you'll mostly be turning to the caretaker or whoever has brought the child in to ask for a history. You're going to get a sample history to catch the most important points which you shouldn't miss. S for signs and symptoms. What were the child's symptoms before coming in? Do they have any allergies? Are they on any medications or taken any medication recently before this whatever has brought them in? Do they have any past medical history? When was their last meal, and what were the events leading up to the current situation? And per the history, you can perform a focused physical examination. Let's say that the child had some kind of history of fever or throat pain. You can examine the throat, you can check the ears. In that kind of way, you can do a more focused physical examination. We also have diagnostic assessments. Again, these are dictated by what your clinical suspicion is. So, but the primary and secondary assessment format of A, B, C, D, E, and sample are standard and should always be done in that way. So, we have finished with the initial impression and evaluation. So based upon these points, you will now identify what the problem most likely is. So is it a respiratory problem? Is it a circulatory problem? Or is it a combined one? Which one is it? And how severe is it? And of course, as we mentioned, you are going to be intervening simultaneously. So what are the two types of broad categories of problems that we can face? Respiratory and circulatory. Within respiratory is what we'll be focusing on in this presentation. So you have an upper airway obstruction, lower airway obstruction, lung disease, or disordered control of breathing. These are the types of respiratory problems, and we'll be looking at them in more details in the next slide. And the severity, is it distress or is it failure? Of course, after a prolonged remaining in a prolonged state of respiratory distress will lead to respiratory failure, which will lead to cardiopulmonary failure eventually, and the final stage would be cardiac arrest. Now, we spoke about upper airway obstruction. Some of the commonest examples of that are anaphylaxis, foreign body aspiration, epiglottitis, and congenital airway abnormalities. So, what will the child be presenting with in an upper airway obstruction? The key points are stridor, voice changes, drooling, snoring, gurgling. So, basically, any kind of sounds and diseases which involve the nose, the pharynx, and the larynx. When it comes to lower airway obstruction, it is the larger airways, the lower trachea, the bronchi, bronchioles. These can be affected in asthma, bronchiolitis, and in these children, the more characteristic features are wheezing, prolonged expiration, more prominent cough. Lung tissue disease, which is the actual parenchyma, most commonly is affected in pneumonia, then other conditions like pulmonary edema or a lung contusion after trauma. So in this case, you will be getting the classic pneumonia kind of picture with grunting, crackles, and hypoxemia despite administration of oxygen. Basically, the lungs are injured or inflamed, so the oxygen is not getting absorbed well enough. And lastly, we come to disordered control of breathing. Basically, it's an issue not with the lungs, rather with the brain or with the central nervous system. So the brain is not regulating the breathing properly, as is in the case of seizures or meningitis, a brain trauma, a brain tumor, hydrocephalus, drug overdose. So in this case, you will find the child having an irregular respiratory pattern, either breathing very slow or with an irregular rate, and shallow breathing, poor effort, or central apnea, which means that they will stop breathing on their own without any sign of obstruction. Coming to the severity, so we talked about distress and we talked about failure. So the key point to remember in distress is that the child is working hard to maintain adequate gas exchange. So they are trying their best to overcome whatever pathology is going on, whether it's an airway obstruction or a lung tissue disease. So they're going to be working hard with an increased rate, effort, work of breathing, but eventually, as fatigue develops, they will progress into respiratory failure. Respiratory failure is defined as a clinical state of inadequate oxygenation, ventilation, or both. It can result from any type of respiratory disease, and when respiratory effort is inadequate, failure can occur without even the typical signs of distress. So it's not always that respiratory distress precedes failure. Let's say you have a child with the disordered control of breathing, he's not breathing at all, so he's gone into respiratory failure without the distress prior. So of course, respiratory failure is a condition which requires intervention because it will progress towards cardiac arrest. Let's look at these two videos. You will be able to tell the difference very clearly. The first baby is having respiratory distress. You can see that this baby is awake and he's tachypnic, he's having nasal flaring, very clear chest wall retractions, and grunting as well. However, this baby
Subcostal
is
retractions.
very
which
ill,
are very
the
severe
baby is obtunded,
in
he's
this
not
child.
responsive, he's having severe
Also note
tachypnea, he's
movement
having
of
head
head
bobbing, he's having cyanosis,
during
and
respiration.
this he is in the tachypnic phase at
I
the
mean to say
moment, but after
breathing.
some time he will be further exhausted and he will not be able to keep up this pace of breathing. So, we talked about identification as well, and let's move to intervention. Now, good team dynamics, of course, are very important because, as you remember, after the initial impression, we moved to call for help, and now we have a team. So, we won't be going through the exact team dynamics, but definitely good coordination and role assigning roles to each team member are critical to have good care. Now, intervention depends on what the underlying cause is. You can have a look at the table on the right side. You can find that depending on what the cause is, you'll be managing accordingly. But one universal intervention which is very commonly required for respiratory issues is oxygen therapy, and we'll be talking about that in the coming slides and ending off with that. So let's look at just one example for each condition. Let's say you have an upper airway obstruction because of anaphylaxis, so you'll be managing with the EpiPen and then with further supportive care like albuterol or corticosteroids. For lower airway obstruction, let's say you have a case of asthma, you'll be giving them nebulization, steroids, and then managing accordingly. If you have a case of pneumonia, as in lung parenchymal disease, you'll be giving antibiotics and nebulization as needed. For disordered control of breathing, let's say you have a child with a increased intracranial pressure. So let's say they have a brain tumor or brain trauma, brain hemorrhage. So you'll be managing the case accordingly, and so the management depends on the problem and which is going on. Oxygen therapy, we know it's indicated for respiratory distress, low oxygen saturation, shock, altered mental status. Oxygen delivery to a child who has retained their consciousness, the aim is to ensure their comfort and minimize distress. If the child is unconscious, then we have to ensure that the airway is protected. There are two types of oxygen delivery. We have low flow modes and high flow mode. Low flow, you have the nasal cannula and the simple oxygen face mask. And in high flow, you have the non-rebreather mask with a reservoir and high flow nasal cannula. Let's start off with the low flow mode. So why is it, a low flow? One of the key features is that it's not tightly fitted to the airway. So it's not, the FiO2 will be lower and it cannot be controlled fully because the room air is mixing with it during inhalation. So a nasal cannula, which is the first picture on the left side, can give an FiO2 of up to 60% and flow of up to 4 liters per minute. And a simple face mask can go up to 10 liters per minute. So just to note, the FiO2 of room air is 21%. So these low flow modes can go give this amount of flow and FiO2. Coming to the high flow, so these are more reliable methods of oxygen and flow administration. You have the non-rebreather mask, which can go up to 95% FiO2 and a flow of up to 15 liters, and the high flow nasal cannula can reach up to 40 liters per minute as per what the child requires at the moment. And of course, there are guidelines for the high flow nasal cannula, where to start, how to build up, how to bring it down. But on a general level, we should know what the low flow mode is and what the high flow modes are, and what the capacity is for providing oxygen. So let's summarize here. We talked about how to approach a child in an emergency situation. You're going to conduct your initial impression or your initial assessment and identify whether this child requires urgent support or not. Shout for help if yes, and activate the emergency response system. Then proceed with your evaluation, primary evaluation, secondary evaluation, identify the underlying pathology, and you have been intervening throughout this process wherever you found an issue going on. Thank you so much for listening, and hope to see you again in another video.